Good afternoon and welcome to the Adelaide Biomed City Minireview webinar series. My name is Andrew Zannettino and I'll be your chair this afternoon. As you would all know, the Adelaide Biomed City Minireviews were established to increase our awareness of the many and varied research capabilities and activities within the Adelaide Biomed City precinct. But before I commence, I'd like to acknowledge the Kaurna people, the original custodians on the land in which we meet today. I pay my respects to their elders past, present and future. I'd just like to remind everyone that you can use the Q&A section of their Zoom window that will allow me to relate questions to the speakers after they present. So without further ado, our first speaker this afternoon is Professor Sepehr Shakib. Sepehr is the Professor of Clinical Pharmacology at the University of Adelaide. He's also the Director of the Clinical Research Facility, which is located within the Adelaide Health and Medical Sciences building on North Terrace. And he's also a Consulting Medical Director at CMAX Clinical Research. He has over 20 years of experience in clinical trials and has been involved in well over 500 clinical trials, predominantly in phase 1, but also involved in phase 2 and 3 clinical trials. In addition to all this activity, Sepehr actually serves as a consultant to pharma and industry, and is also a medical monitor. And for his sins and involvement with the University of Adelaide, he actually runs the clinical trial major for the Bachelor of Health and Medical Science students. So today's title of his presentation is Clinical Trial Support, People and Facilities. And I'd like to welcome Sepehr. Thank you, Sepehr.
Thank you very much. I'll just share my screen and please let me know if anyone has difficulty seeing that. So what I'd like to share with you today is some of the possibilities in terms of facilities and support and people that can support clinical trials within the Adelaide Biomedical City. So if we have a look at the facilities that we have in this fantastic precinct, then these are all the different clinical trial facilities that we have. So I hope you can see my mouse, but we have the Pain Anesthesia Research Centre here. The Royal Adelaide Hospital has a clinical trial facility. There's one within Sammour as well. And this is the Adelaide Health and Medical Sciences Clinical Research Facility. And over here on floors 5 and 6 of this building, we have CMAX Clinical Research. And there's also a UniSA facility, which is outside of this image. So why so many facilities? Well, one is that it allows us to do a wide range of different types of trials. So it can range, for example, from the Park Centre that we talked about, which is 12 beds inside an intensive care unit within the Royal Adelaide Hospital. And this is ideal for clinical trials requiring intensive monitoring, for example, of new anaesthetic agents. So here you can have very, very close monitoring of things such as sedation, blood pressure and oxygenation. And then the Royal Adelaide Hospital Clinical Trial Facility has 9 clinic rooms currently being used for COVID, but generally it's suitable for low risk interventions or follow-up visits. And it has, these range of different facilities. And within the Adelaide Biomedical City, then there's a wide range of different things ranging from these two extremes. The two that I particularly want to talk about today are the ones that I'm involved with. So that's CMAX Clinical Research. So this is a dedicated phase 1 research facility, which was first established in 1993. And all these data here are conservative because I wasn't able to confirm the absolute numbers, but there's over 20,000 healthy volunteers on a database, which is updated regularly to make sure that they're active participants. The staff are nearly 200, so it's actually a very, very big, busy site. And they do approximately 40 new studies per year. And currently there's a new separate GP trial model, which is being launched to help facilitate the recruitment of patient studies, particularly those with mild diabetes and hypertension. The sort of conditions are actually quite difficult to recruit for in tertiary care facilities. The facilities here include 55 beds for overnight and day stays, as well as things such as a 24-bed telemetry unit, a PC2 lab facility, and it has dedicated business development team, a recruitment team, and a GP patient recruitment model to allow recruitment and the design and facilitation of a very large range of different studies. So this is the sort of high-end commercial facility, which is just on our doorstep here within the Adelaide Biomedical City. The other facility that I'm involved with, that I'm currently director of, is the HMS Clinical Research Facility, which is up here on level 4 of the HMS building. And this is now suitable for low to intermediate risk studies. So you can have overnight stays and more intensive studies if the appropriate risk management strategy is in place. This, once again, is a beautiful new site full of light. This is the sort of room that we have looking out onto North Terrace. There's beds, there's proper lab facilities, centrifuges, as well as other facilities for follow-up care and other types of clinic visits. It also includes other things which I haven't shown here, such as a gate lab and a gamma camera and other sort of facilities. The other thing that we should also be aware of is that there's fantastic people within the Adelaide Biomedical City. And here particularly I want to talk about the clinical pharmacology program that we have and clinical pharmacologists. So training within Adelaide is very unique in clinical pharmacology because it specifically trains our registrars in clinical trials, which doesn't really happen pretty much anywhere else in Australia and very rare around the world. And Adelaide happens to have the world's highest per capita population of clinical pharmacologists. And so this allows us to have a wealth of expertise in pharmaceutical clinical trials. So that includes, for example, Paul Wobnitz, who's part of our group. He originally did his PhD in organic chemistry and did an MBA through the Pfizer Accelerated Training Program. He's now a college physician in clinical pharmacology and is in training in oncology. And so he brings a wealth of expertise in preclinical pharmacology, clinical trial design, and drug development. Alongside him, we have Tom Polisek, who originally did a pharmacy degree, then did PhD in drug interactions, and then did an MD. So a couple of underachievers here. And so he's currently Director of Clinical Pharmacology with the Sepehr Corporation, which has expertise in pharmacokinetic and pharmacodynamic modeling. And he, again, has a lot of expertise in design of clinical trials, reviewing clinical trials, and particularly this aspect of PK/PD modeling. And within the clinical pharmacology program within the Royal Adelaide Hospital and Adelaide Uni, we have these sort of individuals. I've just put their names there, but between us, we have expertise. Again, these are conservative in, at least 500, probably about 700 different clinical trials, which includes phase 1, 2, and 3 trials, vaccines, as well as being medical monitors for different clinical trials. And I calculate that between us, we have about 45 years of combined experience in reviewing drug trials from the point of view of the Royal Adelaide Hospital Ethics Committee as well. So in summary, within the Adelaide Biomedical City, there are a range of clinical trial facilities which can cover anything from outpatient to intermediate to high to very high risk drug trials. And to support that, we have a range of clinicians and different scientists, but particularly clinical pharmacologists with specific expertise in clinical trial design, medical monitoring, drug development, and pharmacokinetic and pharmacodynamic modeling. So if you like some assistance in the design of a clinical trial, if you like to discuss where your trial could be done, then I would suggest reaching out to these individuals. So that's my email address. I'm more than happy for anyone to contact me there. I've also included the business development team at CMAX, and there's actually quite a lot of information on the Adelaide Biomedical City website under clinical trials. Thank you very much, Andrew.
Thanks, Sepehr. That's fantastic. Sepehr, before we actually have a stream of questions come in via our chat line, so I would encourage everyone to present their questions to us and we can relate them to our speakers this afternoon. I'd like to get a sort of a sense of the opportunity that the clinical trials infrastructure that we've established here in Adelaide Biomed City can achieve, given that I know that with COVID, clearly there's been some significant interruption in the clinical trials capability across the globe, but clearly we're in a circumstance now where we have COVID largely under control, and I would imagine we would be getting lots of phone calls and requests to conduct clinical trials in South Australia. Is that the case? And where do you see us taking this collection of clinical trial activity broadly across the campus to be a much more unified opportunity. Can you speak to that for us?
Yeah, absolutely. So certainly from the business development point of view from CMAX, which I can speak to, we've been brought a large number of studies that are absolutely ready to go, all the preclinical developments done, ethics approval, and the study's about to be done, and it's had to be stopped because of COVID. And so those trials have been brought to us, and we've done a number of studies, which might be COVID related, but also completely unrelated to treatments and vaccine studies for COVID, for example, where in fact that's occurred, and we're seen as a very, very safe haven. So Australia is always seen as a very, very good place to do clinical trials. We have excellent clinical trial infrastructure, particularly in Adelaide, but also the governance process for clinical trials within Australia is very good and is very fast, because essentially for pharmaceutical sponsor related trials, time is very, very much money, and the governance process in terms of regulatory approval is very quick in Australia. And so it's made a lot of overseas sponsors become aware. They've sought out Adelaide because of the situation with COVID, and they've really been amazed by all the other things that are around that they've been exposed to. The tax advantages of doing trials in Australia, etc. I think one of the challenges for us is how we all work together. So as I talked about, we have a number of different clinical trial facilities that has advantages for all of us. But I think one of the important questions for us then is, how do we collaborate together? How do we share information? I think one of the opportunities, particularly for patient studies, is if in fact they miss out on a particular clinical trial that's being run at one site, how can they access information? Now they can go to clinicaltrial.gov, but what other infrastructure can we set up? Can we, for example, tap into the a volunteer database or a patient database, whilst being very cognizant of issues regarding confidentiality and privacy in terms of how we do that? So I think they're going to be the challenges in terms of going forward, so that we're seen not just as individual sites and silos that are offering clinical trials, but in fact the whole infrastructure that we have then becomes something very, very attractive, marketable and brandable to overseas markets. Absolutely.
Thank you for that. That's look, I do agree there is a great opportunity for us to actually pull together all the activity that we have within each of those individual sites to create a much more productive ecosystem. Just one other follow. I'm really interested by this idea around GP recruitment. This is something that I was actually unaware of until I heard you speak of it now. Is this something that we could do in terms of the public hospital programs of clinical research? That could we work with the primary health networks to actually serve our needs in terms of recruitment of patients into particular trials?
Yeah, so one of the issues has been around so these are actually studies being done within general practice. So as you can appreciate, so a standard for diabetes studies is that you're allowed to be on first-line diabetes treatment. You have to be on stable treatment for 3 months, and that's how they all begin. You can't have any other medications as a general rule. Those patients don't come in to be hospital admissions or see an endocrinologist in a tertiary referral center. So those patients sit within general practice. There's also a lot of other trials, such as, we've done things around, vaccines, sinusitis treatments. You even get treatments for things such as thrush, which we in the public hospital system don't see, but in fact are areas of need. A lot of, simple mental health interventions, again, they sit in general practice and largely in primary care. So this is the opportunity to be able to train up GPs that are particularly interested, to be able to come up with an attractive business model for them, because at the end of the day, it has to be attractive from that point of view, and to allow them to be able to brand themselves as offering something different and unique to their patients in terms of research, and to then be able to offer that to the patients is something that is offered to the general practitioners that work there, and also helps to sort of drive forward the research agenda, trying to find new treatments that are in areas of need that we currently find really hard to recruit for. So it is very, very much about the GPs being trained in good clinical practice, in being trained on the documentation around clinical trials, and actually doing the recruitment themselves. So again, it's a matter of just building those relationships and that collaborative model of being able to work with the public hospitals and general practice to be able to do. Where in fact it's a simple process of the trial being done at one site and the GP simply identifying the patients, it doesn't tend to work well, as we found any kind of system to try and just identify the patients and send them in to another facility generally doesn't tend to work as well as if you actually have people on the floor actually conducting this study. Yeah.
That's fascinating. Look, thanks so much, Sepehr, for a brilliant presentation. It really does show that we have an incredible amount of capacity within the Adelaide Biomed City, and it's something that we need to really see the true value of. So thank you so much for your presentation this afternoon.
Thank you.
Now that leads me to introduce our second speaker for this afternoon, and that is Associate Professor Tarik Sammour. Tarik is a colorectal surgeon at the Royal Adelaide Hospital and an Associate Professor of Surgery at the University of Adelaide. He returned to Adelaide in 2017 after completing a fellowship in colorectal surgery and spending a year working at the MD Anderson Cancer Centre in Houston, where he received additional training in robotic colorectal surgery and advanced colorectal surgical oncology. Tarik has authored over 100 peer-reviewed publications and 7 book chapters. And having completed a PhD in surgery in 2011, he continues to pursue an active research program focusing specifically on clinical trials to improve patient outcomes after colorectal surgery. And his presentation today is Improving Patient Outcomes After Bowel Cancer Surgeries. Welcome, Tarik. Thank you.
Yeah, thank you very much for that, Andrew. I hope you can hear me okay. I'm just going to share my screen now. I guess what we're talking about today is the RA Colorectal Research Group, and thanks again for the invite to present our group's work. We're quite a small group, but quite active in terms of research output. Very focused on one patient subgroup, which is patients undergoing colorectal surgery. The research unit is based within the RA and consists of 6 consultant surgeons, 5 research fellows, and a research officer who helps coordinate everything. We have various streams of research activity, but we tend to focus on colorectal surgical oncology, or basically colorectal cancer and outcomes from colorectal cancer, recovery after surgery, various artificial intelligence applications to solve difficult problems that we face, as well as some contributing to large international collaborative trials. And as far as what we have to offer the biomedical precinct, the key group strengths really are that we are embedded within the clinical service at the RA, and that's both geographically, in that being co-located inside the Royal Adelaide, but also practically. So all of us, including the research fellows, have direct contact and treat patients clinically. The colorectal unit at the RA is a high volume unit with approximately 300 bowel resections a year. The research fellows are all, well, at least most of them have a very strong clinical background, in that they are almost all of them are surgeons in training who've taken time out of training to do clinical research. And so they really have a very strong understanding of the patient needs. We do have a laser focused dedication on patient clinical outcomes. And there's, that's basically every study that we do has to have both patient contributed outcomes, but also the question that needs to be answered must have fairly immediate patient benefit at the end of the study. And that's how we try and keep ourselves at the front line of patient needs research. We are also part of a fairly robust international surgical collaborative network for research, and I'll talk a bit about that later in the presentation. As far as research output, the group was really formalized in late 2017, so it's a fairly young group. But the attraction for research funding, and in terms of research publications in particular, has been growing quite rapidly. And the group has published just over 32 publications. I think it's 33 now since the beginning of this year. There are currently 7 prospective clinical trials that are actively recruiting patients in colorectal surgery at the RA. So I thought it's a bit hard to go through all the studies, but I thought I would give an example of different types of studies in the different streams. So when we talk about colorectal surgical oncology, we have really chosen to focus on an intermediate group of patients. And those are patients that have stage 3 cancer. In other words, they have a colorectal cancer that's gone to the lymph nodes, but hasn't necessarily spread to distant organs. And the reason we've chosen to focus on this group is we think there's a lot of mileage to be gained in terms of improving the outcomes of this particular subgroup of colorectal cancer patients. Lymph nodes, the positivity of the lymph nodes often determines the survival of these patients. And the trouble with this is that diagnosis of positive lymph nodes on imaging or on CT and MRI scans is quite difficult, and the results are often unreliable. And so often we only really find out if the nodes are positive after the surgery has been performed, and we hope to be able to improve upon this. In addition, if we were able to diagnose people before surgery, it's a little bit unclear as to whether surgery is still the right treatment or whether the addition of chemotherapy and radiation prior to this is a better option. And so that's another question we're hoping to tackle. As far as the diagnosis question, can we determine whether these patients have positive lymph nodes or not? We're hoping that AI may have some answers for us. And we've partnered with the AIML, which is a group in the University of Adelaide, but also a high-profile machine learning institute on North Terrace. What you need for artificial intelligence to answer this particular type of question is a large image database and a machine learning algorithm. As far as the first part of that, we at the RA Colorectal Research Group should be able to supply that. And in fact, we've already identified just over 1,000 RA patients, all of whom have had colorectal cancer and have had high quality imaging to stage them, as well as high quality pathological data, which would serve as the gold standard. All these images have been extracted and downloaded after ethics approval, and we're currently busy, one of our research fellows is currently busy segmenting the lymph nodes to be able to train the machine learning algorithm, which is currently under construction by the AIML. We have ethics and funding for 2 studies that will result from this. The first is simply an analysis of the AI performance. Can it predict positive lymph nodes? And because we have the pathological data, we can use that to inform both the training and the assessment study. But a second study also where we hope to combine both the AI and a specialist radiologist assessment in real time to compare the performance, but also to see if we can augment the performance with both elements feeding off each other to give us a better answer as to whether the lymph nodes are positive or not. As far as the management part of the equation, so if we could find out if the nodes are positive, should we be changing the treatment? And one model for this is rectal cancer. So in rectal cancer, in advanced rectal cancer, the traditional model is shown here on the screen. And typically what we would do is we would zap the tumor with radiation, then undertake surgery after a wait period, followed by chemotherapy afterwards. The problem with this traditional model that we have been using for many years now is that a significant proportion of the patients never get to the chemotherapy. And that's because they suffer complications and delays related to the radiation and the surgery. We estimate approximately 30% of our patients at the RA prior to our change in paradigm were not receiving the chemotherapy. And that's particularly important for patients that are node positive because chemotherapy potentially could make quite a big difference in this patient subgroup. And so internationally, as well as locally, there has been a move towards moving the chemotherapy earlier before surgery to try and maximize the chances of the right treatment being given at the right time. This is termed total neoadjuvant therapy. So in a sense, in patients with advanced disease, they would get radiation and chemotherapy prior to surgery. What we are hoping to do at the Royal Adelaide, and in fact we've started doing, is to further personalize the treatment so that the order of the radiation and the chemotherapy can also be swapped depending on whether the patient is node positive or has a risk of distant metastases, in which case those patients would get the chemotherapy as their first treatment, given it's the most important component. This is a prospective study we're doing, and in fact the program started in January 2019. So far, as of today, we've had 53 patients included in this program where they've received personalized total neoadjuvant therapy. 24 patients have completed the treatment, with the rest still in various phases of radiation and chemotherapy. And I'm happy to report that of the 24 patients that have completed the treatment, 54% had no residual cancer at the end of their radiation and chemotherapy. The photo on the top right of the screen is of a patient with a rectal cancer. And the rectal cancer used to be in the location of the dotted lines here. As you can see, it's almost indistinguishable from normal bowel. So this patient is now a year down the line and has not required surgery because the tumor is gone, as far as we can tell. So the next steps are potentially expansion to other sites, and we have been talking about potentially expanding to some other sites around Adelaide, as well as the possibility of a statewide consensus, which would give us obviously more data to go on. Another exciting prospect is whether we can further target the treatment to the right patient using the biomarkers and AI staging, and obviously we're actively working on that at the moment. So that's a bit of a flavor of the surgical oncology research we're doing. I'll skip on to surgical recovery. One of the biggest problems, in fact, the biggest problem for recovery after bowel surgery is the fact that the bowel tends to go to sleep and stops working. This is termed ileus. This is an X-ray of a patient with dilated bowel, which is just not moving and not pushing anything through. ileus is defined as gut dysfunction occurring after surgery. It is an unpleasant experience. It causes vomiting and bloating and generally bowels not working. It's a very common complication. At the RA, it's over 30% of our patients will have this problem in a significant way. And perhaps even more importantly, it's associated with some pretty serious complications and is the most common cause of death after colorectal surgery in the short term. We don't do much about it. In fact, the treatment for ileus is very limited. We really only treat the symptoms. We drain the stomach and we give people supportive fluid therapy and we wait. And in fact, there has been very little advance in this area in many decades. An example of how we're trying to tackle this is we've started with a very simple trial where we've decided to randomize people to receiving multimodal laxatives versus standard of care. This trial started in August 2018 and was completed this year with 170 patients recruited. This slide shows the results of this study. And in fact, we've managed to cut down the rate of the incidence of ileus quite significantly from 37% in the control group to 22% in the Stimulax group. This was supported by the fact that the time to a bowel movement was reduced by 1 day, as was the length of stay, although that wasn't statistically significant. And quite importantly, the rate of grade 2 complications, which is the most common grade of complications after colorectal surgery, was dramatically reduced, and most of this was related to ileus. Interestingly, there was no difference in cost between the two groups. In fact, if anything, it was cheaper in the Stimulax group, again indicating a reduction in complication and hospital stay. This shows our primary outcome, which is GI2. GI2 is time to tolerance of solid diet and passage of stool, which was again a day shorter in the Stimulax group, the group that received laxatives. Laxatives are now a standard component of our enhanced recovery protocol directly as a result of the study. But we haven't stopped there. Now that we've established a baseline, we think it's time to move on to a more novel approach. Our next study will look at pyridostigmine. Pyridostigmine is an acetylcholinesterase inhibitor, which is used to stimulate bowel motility in settings outside of surgery, typically with functional bowel obstruction. It's never really been trialed in a bowel surgery setting. The reasons for that are unclear, and we're hoping to address that. With this study, because of the novelty, we have started a phase 2 safety powered study. And that has started recruiting. I think our third patient's being recruited this week. If this study shows that pyridostigmine is safe, then we will move on to a randomized controlled trial to see if we can reduce the rate of ileus even further. So that's an example of our recovery studies. Again, there are a few too many studies to go through, particularly with the international collaborations. There are way too many studies that are currently recruiting, but I'll give an example of one, and that is the Sunrise trial. The Sunrise trial looks at, it's a large multi-center randomized controlled trial looking at the use of negative pressure suction dressing on top of high-risk wounds, in this case, emergency abdominal surgery wounds. The primary outcome is wound infection, which is a very common and high burden complication in this patient subgroup. We are one of 30 hospitals that are recruiting. The UK started recruiting a year ahead of us, but we're slowed down because of COVID. And in fact, the recruitment rate at the Royal Adelaide Hospital has been higher than any other hospital internationally, which is a fact that we're very proud of, and is a testament to the research fellows and the registrars at the Royal Adelaide Hospital who have helped support this study. So that's really just a brief overview of the sorts of research we're doing. There is a lot more detail on our website if anybody would be interested to look at this. So it's colorectalresearch.org, and you'll find details about all the studies that are currently running and ones that have been completed. Again, thank you very much for the opportunity. And on behalf of the RA Research Group, we would welcome any questions and happy to collaborate with any future research programs that would be relevant. Thank you.
Thanks, Tarik. We have a minute to go before we need to close off, but I would like to ask one question if I could, in the absence of any questions coming online. Look, clearly one of the things that people are challenged by is, with bowel surgery in particular, is a colostomy bag. And I was wondering whether, in fact, the sort of social issues associated with that particular thing is something that your research team is examining, because I see it as being a really big issue with particularly with patients being, having to consider that as being something that they may have to have for the rest of their lives, or at some point have removed. But can you speak to that for me?
Yeah, so we don't have any active research programs specifically looking at the psychosocial aspects of having a stoma. However, I will say that the commonest group that requires a stoma, both temporary and permanent, are patients with rectal cancer. And so in reality, if we have our way and our research is followed to its natural conclusion, our hope would be that the number of patients that actually require an operation that results in a stoma will disappear in due course. And that's really our goal. So it's a prevention is better than cure type of strategy that we're employing. However, I think absolutely there is scope for further research that tackles the question as to why is a stoma unacceptable, and is there anything we can do if a patient still requires it? Can we find ways to mitigate the impact of that on the patient, both from a social and a psychological point of view?
Thank you, Tarik. Look, I'd like to once again thank Tarik and Sepehr for giving two fantastic presentations of the type of work that is occurring here in the Adelaide Biomed City. I'm really appreciative of your time and commitment to presenting this afternoon. Before we close off, I'd actually just like to remind people that these mini reviews are being recorded and are actually available on the ABMC website. The mini review webpage is at Adelaide, www.adelaidebiomed.com under the banner webinars, where you can watch this and past recordings. Again, please join us next week at the same time, where the focus will be on cancer. And the speakers for next week's session are Professor Doug Brooks and Professor Greg Goodall, and the session will be chaired by Professor Susan Hillier. So from here at the Adelaide Biomed City, I'd like to once again thank our speakers for this afternoon, Sepehr and Tarik, and welcome you to join us next time, same time, same bat channel. Thanks so much. Cheers.